welcome everyone listening in from other sites. Thanks for your interest in our education series. It's nice to have people linking in and having listened to what we present each week. So we were asked to have a presentation on the inpatient unit, which we hadn't done before. So for those of you that are working, for example, outside of the health system or in peripheral health sites, mental health system, hopefully this will give you a guide as to what the inpatient unit does and what we're able to do to help your patient. And then at the end, towards the end of today, we'll have a brief presentation about how you actually refer patients, how you get patients into the inpatient unit. So my name's Mike. Before I start, I'd just like to acknowledge the traditional owners of the land upon which we meet today, and to pay my respects to elders past, present and emerging. So the outline for today's talk is to show you where we actually are and what the inpatient unit looks like inside, so where you'll be sending your patients to, basics of withdrawal management and what we do, and then some more specific things related to people that have problems with opioids and problems with benzodiazepines. And as I said at the end, some more information about referral pathways and how you get patients in here, and also some contact information. So first off, this is where we're located. So it's quite central CBD, about 2 minutes walk from Royal Perth Hospital, on the site of the East Perth Next Step Community Alcohol and Drug Service, and that's at 32 Moore Street. To give you a bit more of an idea, just give you a bit of an idea of what it looks like inside. So this is the entrance to Next Step, and the reception waiting area, a couple of the rooms in the executive area. This is a bit of a map of where we're located. So on Moore Street, we're just near Wellington Square, and that's a blocked out area. On your left-hand side, you can see that cross is basically our outpatient service, and then towards the right-hand side is the inpatient service as well. So that's giving you an idea at least of where we're located. Ryan, would you mind shutting the door, please? Apologies for all the noise, folks. Hopefully that will be settled now. So just wanted to talk briefly about how we fit into the health system, our inpatient unit itself. Just gone over where we're located. Everyone knows what central city sort of location we are in. In terms of the setting, medical setting, we're not a hospital inpatient setting. So for patients that would need things like intravenous therapies, potentially advanced monitoring like cardiac monitoring, potentially rapid access to pathology or access to intensive care unit or high dependency unit, this is nothing of what we can provide here. So patients that are at high risk of things like delirium tremens, for example, that would need a high dependency unit or potentially an intensive care unit if they did deteriorate in terms of delirium tremens. These are not patients that we would be able to manage here. So it's important to keep in mind what sort of setting this is. It's what we would call a community-based medical unit, not unlike a rural hospital, but even with lower acuity than a rural hospital, because again, we don't have access to intravenous therapies here. We don't have oxygen cylinders, for example, at the end of each bed, or oxygen contact through the wall at each bed. So there's a limited amount we can do, and it's important to keep that in mind. So we would see patients that are at risk of having seizures, for example, in alcohol withdrawal, having complex medical conditions that are at this particular point relatively stable, potentially complex psychiatric conditions, but again, at this point when we see them stable, and we have medical support available 24 hours a day. So we fit in between a hospital inpatient service and then other services that are non-medical and community-based. So for example, Bridge House, it's run by the Salvation Army. They have their site not far from here over in East Perth, and they have a withdrawal unit as well, but it's not served by medical staff. There's no nursing staff on site. So these patients would be at much lower risk than the patients that we see. So we sit in between a hospital and a non-medical detox or withdrawal unit. In terms of the physical environment, I showed a picture just earlier of the outside of Next Step at 32 Moore Street. This is the inside of the inpatient unit, some of the areas of the inpatient unit, obviously the lounge room, communal dining area, a large outdoor area for exercise, not unlike a community psychiatric unit in terms of its residential sort of nature. Some of the important policies to understand when you're considering referring a patient. It's a smoke-free environment, as all WA health facilities are now, and we provide abundant nicotine replacement for those people that need it. And for some people, we would consider starting things like varenicline or Champix. Patients are not allowed to have any visitors that come into the site. They're not allowed to have access to their mobile telephones. There is no internet access or personal internet access. When patients arrive the first day, there is a search of their clothes and luggage. It's not a physical body search, but it's a search of their clothes and their luggage, because in the past, and occasionally we do have people that bring substances into the unit that we can't allow onto the unit. Patients need to remain within the boundaries of the unit. It's a voluntary service. It's important to remind patients of that. It's a voluntary service, so you can leave whenever you want to leave. But in terms of coming back, we need to have a period of time, usually about 2 weeks or so, before people can come back in if they do leave the boundary of the unit. Medications, we take hold of the medications like you would in a hospital, and they're dispensed by nursing staff according to a medication chart, which is written by doctors, as you would expect in a hospital. And sometimes we do look at medications that potentially are not in the best interest of the patient, and they're not returned when the patient leaves. There's no exclusive relationships. We discourage drug raving, discriminatory behaviour, those sorts of things, and I think that's important to let patients know so that they feel safe and they're sure that they're coming to a safe environment, which they are. Okay, so that's about the unit. That's where it's located. It's a little bit about what happens when people get here and what it looks like. Let's just look now in this next section about what we can actually do for the patients that you see. So in terms of, I guess, fairly straightforward withdrawal management, patients coming in for opiate withdrawal, alcohol, cannabinoids, stimulants, clearly in WA that's crystal methamphetamine in the main, and benzodiazepines. So you'll notice there on that slide there's varying times for different substances, the length of admissions for various substances, mostly 7-day admissions. For opioids and benzodiazepines, that can go out to 14 days, and you'll notice for benzodiazepines it's a pretty low dose, daily dose of diazepam equivalent that we feel comfortable withdrawing someone from, and it's a reasonably long admission, and that's the nature of benzodiazepines. So when you've got patients on high doses of benzodiazepines, withdrawal is usually not an option, and we'll talk about what we can do to help with that in a minute. So some of the things that we would do apart from an alcohol, just to go back, so again, apart from alcohol withdrawal, cannabis withdrawal, methamphetamine withdrawal, and those mentions there are benzodiazepines, just some specifics now. In terms of opioid withdrawal, some of you will know that when people run into problems with opioids, they have our main treatment is to commence opioid substitution with either buprenorphine or methadone. And so at the end of the treatment episode, whether that's 1 year or 10 years or 6 months, people are ready to exit opiate replacement treatment. They can come into the inpatient unit and we can do a withdrawal of the last sort of part of their treatment. So the methadone dose at that stage towards the end of treatment needs to be at 20 milligrams. And they need to have had 20 milligram doses every day for around about 2 weeks before we would accept them in. And for buprenorphine or Suboxone, the dose needs to be 8 milligrams or less. Again, for around about 2 weeks before they come in. These are 14-day admissions because methadone and buprenorphine, as you might be aware, are long-acting medications, and it does take a little while for withdrawal to settle in and to start. And we really, this is the case, and I'll emphasise this now, that we really like people to have a sound post-discharge follow-up plan. And that may be the experience of some people when they might sort of feel it's difficult to get into the unit. We ask for lots of things before patients come into the unit. It's mostly around having this sound discharge follow-up plan because we know very well from the evidence and from experience that people do poorly when they come in for a withdrawal episode that's really not very planned or not well planned, and the post-discharge plan is not well established. So, for example, for completing opioid substitution treatment, you can see some evidence there that in the first 4 weeks after methadone treatment exit, there's about a 2 to 3-fold increased risk of mortality in that initial period. And that doesn't seem to matter how people come off methadone or stop methadone. Suboxone or buprenorphine, also much the same, around about a 3-fold increase in mortality in the first 4 weeks. The paper I've just listed there for your interest. So it's really important for these patients, at the level of mortality importance, to have a good sound follow-up plan before they come in to do this last part of their treatment and go through withdrawal. What do we do for withdrawal? We use clonidine, we use buprenorphine in some cases for people that are really experiencing significant withdrawal, and other than that, symptomatic management, containment, education, and psychosocial support. When we now talk about withdrawal from illicit opioids, that's a different case. So again, just stressing that the last slide was about people exiting from a planned exit from opioid substitution therapy that's been going for some period of time. In this particular case now, this slide is talking about referrals for people that might be using heroin or codeine or illicit street opioids. We would consider this on a case-by-case basis, but we are reluctant to admit these patients in general. All we really do, and it's important to consider this, is take away people's tolerance when we do a physical withdrawal. That's all that the medical period with us does. What that does is then put these people at high risk of overdose if they do relapse. And we know that there's a high risk of relapse for opioid use disorder, particularly if it's a brief, sort of abrupt inpatient admission that's not very well planned. So we said there's a 3 to 4-fold increased mortality risk when you stop opioid substitution treatment. Some studies have shown there's a 130-fold increased risk of drug overdose, and the majority being opioids, when people are released from prison, for example. So I'm not saying that that's the case always. I'm not saying that 130-fold is the number to remember, but I'm just saying that some studies have shown that, and that's roughly the equivalent of what we're being asked to do when we're asked to withdraw someone from heroin that's walked in off the street, essentially. So alcohol withdrawal, 7-day admission. Diazepam is the medication of choice to manage alcohol withdrawal symptoms and to prevent things like seizures, and also to help people be comfortable and asymptomatic. Other symptomatic treatments, antiemetics, etc., nicotine replacement we give, and for all patients, education and psychosocial support. Although alcohol is a very common substance for us to see, probably 70 to 80% of our admissions. It's important to just consider loss of tolerance here as well. And whilst we probably don't think about this, again, 5 days admission, people now have no tolerance to alcohol, no different to someone who's alcohol naive. So if they were to drink a bottle of spirits quickly on the day they left or 2 days after they left, they are at significant risk of overdose as well. And I'm never that keen to raise celebrities and these sorts of things, but I think it's a good case to remember is Amy Winehouse's, the singer from the UK, the young singer from the UK that died of an overdose. So her coroner's report was alcohol poisoning or alcohol toxicity, and she had had a period of withdrawal and abstinence just prior to that night where she drank a couple of bottles of vodka or whatever it was. So it can happen. It's not all that different to opioids. We just don't see it as often, but it's worth considering. So cannabinoids and methamphetamine withdrawal, look, there's really no established pharmacological treatments we can use, symptomatic management. Nicotine replacement is very important in cannabinoid withdrawal because in Australia most people mix tobacco with their cannabis. Again, education, psychosocial support and a sound discharge plan if we're aiming for abstinence. Benzodiazepines I mentioned just briefly, I won't go through them again, sorry about those pictures, they're irrelevant, that's my mistake. So 14-day admission and low dose diazepam, 10 milligrams per day before they come in. So now looking at some of the things that we can do other than withdrawal management. So that's all our withdrawal. What else can we do to help your patients? So when you have a patient that wants to, or you think and they agree that they want to start on opioid replacement therapy for an opioid problem, sometimes that's pretty straightforward, other times it's not. If they're using other substances that also cause sedation, commonly benzodiazepines, more commonly these days as well pregabalin, or alcohol, it's important to consider the risk of overdose in those first 4 weeks starting treatment, because the risk of mortality in the first 4 weeks of starting opioid replacement treatment is not that different from the 4 weeks when people stop. So that's the high risk period of overdose and accidents. So we can take people into the inpatient unit who might be taking more than 20 milligrams of diazepam a day and they want to start on methadone. You can see the numbers there for buprenorphine. They might be on high doses of pregabalin, they might be drinking too much. We can do a detox at the same time, or a withdrawal management for their alcohol at the same time as starting them on the opiate replacement that you want them to start on. Additionally, if you're not really sure as a doctor in the community or a nurse practitioner and you're really not quite sure of their tolerance to opioids, so you're a bit concerned about starting them on a daily dose of methadone or buprenorphine. They might be using opioids 2 or 3 times a week and still be at very high risk, but not using every day, so their tolerance is unsure. Then we can take them in the inpatient unit. It's a much safer place for them to be inducted onto opiate replacement therapy. The other couple of considerations, and this is the same really for alcohol-dependent patients, patients with cannabis use disorder. If they've got a co-occurring psychiatric illness, as I mentioned earlier, or a co-occurring medical illness, these slides deal with medications that interact with methadone and Suboxone. That's what this slide is mainly about, but it's also about patients that have other problems along with their alcohol that wouldn't be suitable for somewhere like Bridge House's withdrawal program that Next Step can help with. The other opioid induction problem can be patients that just try to start their Suboxone, for example, and just never manage to get to the pharmacy or never manage to start that first dose because they're concerned about a thing called precipitated withdrawal. I won't go into too much detail, but people can get sick if they are not able to stop opioid use and have a period where they're starting to get into opioid withdrawal before their first dose of buprenorphine. So they can get quite sick. Some people are really quite terrified about withdrawal. They struggle to experience it at all. They never really get to the pharmacist. So again, we can use smaller doses of buprenorphine in the inpatient unit, which you can't use in the outpatient circumstance, and we can get patients that have struggled to start onto buprenorphine started in the inpatient unit. And that goes for the newer versions of buprenorphine, now the depot medications as well. Some of you might have patients that, in particularly these days, as I just mentioned, there's the new depot version of buprenorphine that seems to be quite popular for lots of obvious reasons for patients. They might be on methadone and heard about the depot buprenorphine and they really want to try that themselves. When they're on 80 milligrams of buprenorphine, our guidelines recommend that they need to wean down by 5 milligrams a week until they get to 40 milligrams, and 2.5 milligrams a week until they get to 30, before we can transfer them over to buprenorphine. So that's a number of weeks. If patients are keen to start and you think they're suitable, we can do transfers from high doses of methadone. We've said we'd rather not have a fixed number, because I don't think fixed numbers work all that well. We need to consider things on a case-by-case basis, but we have done transfers from doses of methadone of 80 milligrams and thereabouts. Again, using small doses of buprenorphine that you can't access in the community. So high-dose transfers from methadone to buprenorphine are another thing that we can offer. In a similar manner, patients that are on very high doses of prescribed S8 opioids, the Department of Health is no longer approving their S8 opioid medication doses, or they've been advised that they must start on a opioid replacement therapy. So again, this is something that we can do. We haven't done a lot of it. We have done some. We're sort of at the stage of case histories at the moment, so we haven't got even probably enough for a case series yet. But using, again, small doses of buprenorphine, it is possible. There's been a number of studies from a group in Canada that Renee Whitelingham, who's my other consultant, knows in depth. So it's being done overseas. We have some knowledge of it, and we can do that as well for people that are on high-dose prescribed opioids that need to get onto buprenorphine or methadone, particularly buprenorphine. And then finally, for those patients that you see taking high doses of benzodiazepines, potentially coming in and talking about diazepam equivalent doses of things like lorazepam, clonazepam and alprazolam, up at 80 to 100 to 150 milligrams per day. What to do with those patients? Really, really difficult. You can't prescribe. If you want to transfer them over to diazepam, which is the recommended treatment pathway for people with that problem, you can't be prescribing 150 milligrams of diazepam per day in a GP practice or a psychiatry practice. You can't even keep up with the PBS scripts, or private scripts for that matter. So what we can do is see these patients, stabilise them onto a semi-reasonable dose, usually somewhere between 30 and 40 milligrams of diazepam equivalent per day. Try and reduce them a little bit. It's usually, we usually can't reduce them by too much, but hopefully discharge them on something like 30 to 40 milligrams of diazepam per day that then can be weaned gradually in the community. So that's another thing that we can help with when you've got these patients with high levels of benzodiazepine use and chaotic use and illicit use. All right, so the last part of today's talk, I just wanted to potentially run through. I've got our manager of the East Perth site, so Liz Lang's here, and one of the CNS, our two CNSs, clinical nurse specialists in the unit, Michelle. So we'll just go through the referral pathway. Michelle, do you want to talk about that, or do you, Liz, or shall I continue? What would you like?
You continue, then if you can't question, so that's okay.
So if people have got questions, it's really a good time now to ask. We've got two of the people that deal with this all the time. Apologise for my heading. So developing a treatment plan, as I say, and part of that treatment plan requires an inpatient admission. So you need to complete a couple of forms that we can supply through email to you, which is a referral form. The internal referral form just refers to people that are already in one of the the community alcohol and drug services. If you're not, then there's a different referral form which we'll fax to you. Patients need to sign a contract, which would be signed with you as their main treatment provider, whether you're a psychologist or a counsellor or doctor or nurse. That contract basically goes through all of our exclusions, some of the ones I mentioned earlier today. Sometimes we ask for things like an anxiety management plan or emotionally unstable sort of a plan to manage situations that people might find difficult in the inpatient unit. We have examples of those, so we don't expect you to come up with them yourself, but we've got examples that we can email to you. We like to get some pathology results if they're available, if there's a current mental health care plan, if that's available, if there's a solace report, if there's severe psychiatric illness, if that's available, that's helpful. And then a release of information so that we can get any further information we need. Privacy statement like most services have. And then we would ask you, obviously we'll give you all of this first, don't expect you to try and find it, but ask you to give the client, there's an admission information brochure, the checklist where what people can bring in, what they can't bring in. We give you a copy of the structure of the program so they get a bit of an idea of what they're going to be doing every day, and sometimes that reduces a bit of anxiety. And we do have the inpatient withdrawal unit walkthrough video that's on the MHC website, Liz. Again, rather than you trying to search for it, we can send you a link where you can take your patient through a walk through the unit for those that are pretty anxious about coming in, and it's an anxiety-provoking time when they have to first come into the unit. What happens then is someone like Michelle will accept your referral and then gather your referral and then ring your client and discuss the referral with them, just check the basic details, and then also will then explain to your patient what needs to happen for them to come in, book a time. The CNSs will also, or someone like Michelle will also speak to Renee or myself if we're not quite sure whether this is a suitable referral, and we'll talk about that, and we'll talk about that with you. We can do face-to-face appointments for this screening process, or we can do them over the phone. They're mainly done over the phone, Michelle, yeah? So it's important when you do put an inpatient withdrawal unit referral in, and you talk about this with your patient, to have an up-to-date phone number, because it's really difficult, Michelle, is it not, for contacting patients, and sometimes you as a provider, you'll get frustrated. The patient will come back and say, look, I haven't been contacted, and you're not sure what's happening. Often that's the fact that we just can't seem to get the patient on their phone. So that's a really, really important thing to mention to them.
They can also contact CNS directly on that number.
Sorry?
The client can also contact the CS team directly.
Right, yes.
So if they haven't heard from us within a couple of days, then encourage them to call us, and we're happy to screen them then. Great.
Okay, so sorry, if you hadn't heard that, Liz was just saying that the number there, 92191819, patients can ring that number now and speak directly to the CNS team and can do the screening then, or they can arrange a time with the CNS team to do the screening, because that can be a bit of a block for people coming in if we just can't contact them. So basically sometimes we either don't have enough information that we're comfortable with, we're not quite sure that this is a suitable referral. The CNS team will contact you as a referrer through email and let you know what the situation is and what potentially more information you could provide, or how we might progress forwards. Okay, and then lastly, so the CNS, so someone again, like Michelle will send you information about when the bed has been booked for the patient, so that you can have that on file and remind patients if you see them. That's about all I think I've got to add. Is there anything else, Michelle, that you want to add?
That's fine.
Okay, Renee, anything you think of that we can clear of? Anything else? Guys from the unit? No? All right. We've got, as I said, Liz and Michelle here, so I'm just going to turn the volume up. If you've got some questions about the unit and how we can help, please, we've got Renee and myself as well, so now's the time to ask if you've got questions. As usual, none.